I would like to go ahead and introduce our honored guest, Dan Holohan. Welcome, Dan. Thanks for being here.
Thank you, Chris. Thank you for having me.
Yeah, absolutely. Let's start out. Tell us just where you are and what you're doing, and then we'll kind of get into your background, and then we'll catch up to the present as far as your research. So who is Dan?
Sure. I am a graduate student at Syracuse University. I actually live in Long Island right now, so the program is online and my field work is on Long Island. It's a 3-year program, so I'm about a little more than halfway through in total. I'll be graduating next year. Um, and so the misophonia aspect of my education was not something that was expected going in. It is something that I started doing as a project for a research course. I brought it to the attention of some of the Syracuse faculty, and they were very receptive. And so I've continued to collaborate with them on producing some original work, some conceptual papers. I had written one paper that was accepted for publication and is currently in press. So it's not currently publicly available, but should be soon. And then a second paper that was recently submitted, and we'll find out more about that one soon.
Awesome. And how, I know the answer to this, but how did you come to research and be interested in misophonia? What's your background there?
Sure. I've had misophonia since I was about probably 11 or 12 years old. It's something that's had a profound impact on my life. Um, the decision to start studying misophonia was actually as a coping mechanism. I was told by a misophonia specialist in, I believe, 2018 that the more I learn about misophonia, the more I will be able to manage the symptoms of it. So at the time, I learned a bit about it. And then when I entered this program, I decided to really, learn a lot more, read peer-reviewed articles, journal articles, and I have found it's been helpful for me in managing my misophonia and in bringing some of this knowledge to social workers in general.
Awesome. Do you find that I also have misophonia? Do you find that since there is so much research, and you, as well as our previous guests a couple of weeks ago, are sort of outside of the clinical box, so there's research happening that is outside of strictly clinical settings. Most of the research that's been happening has been on figuring out the brain mechanisms and the possible treatments that we could look to, coming up with assessments, looking towards diagnostic criteria. But yours was one of the first that was outside of that clinical realm. I know you're a clinical social worker, but social work is a new field that we're excited to see in the misophonia research realm. And do you find that all of that research that's happened so far helps you have more confidence when speaking about it and bringing it into the social work industry and viewpoint?
Yeah, absolutely. I think every article of research is helpful to be able to speak with some authority on the causes or um, different diagnostic criteria, comorbidity. Each of that is really helpful in being able to go to social workers and say, hey, here's what's going on. We know this, this, and that about this, but here's what we don't know. And so far, we've seen a lot of research from psychologists, psychiatrists, audiologists, and some neuroscientists. And the research they've produced is really genuinely great and helpful. At this time, I'm not aware of any article that's been published in a journal of social work. I'm aware of one article that was co-authored by a social worker, but it's something that my profession is not really involved in right now, not really aware of. And that's something that I'm hoping can change, especially with this paper.
Awesome. And one of the things, maybe to bring it back down to like really a basic question, I say this at every science session, but I'm a theater guy. I'm not a clinician or anything like that. How would you define social work? What is social work? I know that seems like a really silly question, but a lot of people aren't really sure what is included in that.
No, that is a great question, and I spent much of the past 2 days thinking about that question because I'm used to explaining misophonia to people who don't know what misophonia is, but do know all about social work. But tonight I'm, talking to people who might know a good deal about misophonia, but less about social work. And so I did write down a little definition here.
Go for it.
Social work is the mission of social work is to enhance human well being and help meet the basic human needs of all people, with particular attention to the needs and empowerment of people who are vulnerable, oppressed, or living in poverty. And so that is taken verbatim from the Social Work Code of Ethics. And in that definition, it necessarily implicates mental health, right? It's talking about the needs, the basic human needs of all people. That's going to include mental health, but it's not limited to mental health. I think when people think about social work, they are imagining sort of the therapist and the client in a room together, the classic therapy model. But the reality is, most of the clients that social workers interact with and encounter are going to be in public settings like schools or hospitals or rehab clinics, um, mental health clinics. Um, and occasionally you might meet them at their home due to home visits. Um, but that's something that really separates social work from psychology, psychiatry, some of the other fields we're talking about. Not to say that those groups are not meeting clients in public spaces, but it's more common in social work to really engage in that direct practice. And that's really important to mention because a, a social workers have an opportunity to sort of catch misophonia in the wild. If you are in a school and you see a student who is leaving the classroom every time someone is chewing gum, if you're a social worker who does not know what misophonia is, you might diagnose that person with oppositional defiant disorder and say they are being non-compliant. Or you might hear that they have sensory issues and you might assume autism and you might confuse it with the sort of sensory defensiveness we see in people on the spectrum. So if you do know about misophonia, you are able to avoid a misdiagnosis. And that's maybe the most important part tonight of this that I think social workers' role in treating misophonia, avoiding the misdiagnoses, because clinical social workers are one of the professions that can diagnose people. And if you end up diagnosing someone with misophonia, well, if you diagnose someone who has misophonia with OCD, and then refer them to a psychiatrist who specializes in OCD, you're going to be treating that person and medicating that person for a disorder that they don't have. So that is really key here. Going back to the definition that I said before, the empowerment of people who are vulnerable, oppressed, and living in poverty, it's also really important that we are looking at different identities, whether it's race, class, socioeconomic status, and understanding how that interacts with misophonia to constitute someone's experience, really. When we're talking about vulnerable people, we're thinking about young people, children, the elderly, people with disabilities, people who are struggling to communicate their disorder. It's the role of social workers to help that individual communicate their needs, whether it's to the psychiatrist or to the teacher or to their parents or spouse. And then living in poverty, poverty is going to exacerbate any mental health condition, and misophonia is no exception.
Absolutely. Yeah, the last time we talked, that was two of the things you just said really sparked my interest the last time we spoke. And the first is access to medical information. and
Mhm.
medical care. So you're right, income, location, age, all of those kinds of things can greatly limit one's even knowledge or ability to learn about misophonia, and access to that care. So people who don't have internet at home or don't have a car or anything like that, those are going to be big barriers to even finding out what it is. And social work seems like a really key, I don't know what the word is, window or crack into that, where it could be incredibly valuable. Shout out to libraries. More and more libraries are hiring social workers to have in house. I'm speaking on behalf of Michelle, who's actually here, but she's a manager of a library, and they are just starting having full time social workers to provide resources, to provide the kind of care. And so the on the streets, wherever it may happen to be, information about what misophonia is was something that really sparked my interest. How might the social work profession or industry or community best spread that message to maybe people who wouldn't normally get it through a doctor if they don't have one or something like that?
Well, it's definitely an uphill battle. Um, Spreading the message about misophonia, I think it does start with talks like this tonight. It starts with articles in peer-reviewed journals. It also, an important piece is for the people who write the articles, these research articles within the journals. I think it's so important to have complementary pieces that are publicly available and written in accessible language. And so um, I try to write my articles in the most accessible language possible. I believe that's my responsibility as a social worker. I know people in neuroscience don't have that privilege. Um, but there's been some tremendous work from people who've produced original research, turning that research into a publicly available and accessible resource. Dr. Jennifer Jo Brout with the Regulate, Reason, Reassure Coping Skills program and some of her other work. I know the University of Sussex Misophonia Hub
Mm-hmm.
is an excellent source of information, as well as the Duke Center for Misophonia and Regulation. If you go on their website, you can find a lot of helpful information. So, to anyone engaging in misophonia research, I would encourage them to, create those pieces that are also more accessible to the general public and to professions without maybe the special knowledge of neuroscience or psychiatry. In terms of social workers, I think it's really important that social workers are collaborating with interprofessional treatment teams. And so, if you are a social worker who is aware of misophonia, let's take an example. Let's say you are treating a 12-year-old child. Um, Working with the child's psychiatrist, the child's teachers, parents, and other significant family members, working with the school psychologist, and then, of course, other social workers and any other relevant professionals to inform them of what misophonia is, and how it plays out for the client.
Absolutely. Something that thank you for that. That's a great answer. Something that really um, was super helpful to me, and also sparked that aha moment last time we talked. I did not know this, but as you mentioned earlier, clinical social workers can diagnose people. And even though we don't have diagnostic criteria yet for misophonia, I was very delighted and surprised in a good way to find out that it's not just your local psychiatrist or psychologist or pediatrician or whoever, but a social worker can actually
Mhm.
diagnose somebody with something. So when we have those diagnostic criteria, that's another place that people can find that kind of validation. How
Yeah.
does that work?
So, in order to diagnose someone, you need to be a licensed clinical social worker. Um, the the standards are going to differ by state within the United States. But basically, when you graduate from an MSW program, you become an LMSW, licensed master of social work. After a certain number of hours, you will become a licensed clinical social worker. And licensed clinical social workers are able to diagnose people. So that is a huge responsibility of our profession and something that should not be taken lightly.
Absolutely. I can also imagine, one of the things that is kind of I don't know what the word is, not a sticking point, maybe it's a sticking point, is what we talked about, the clinician issue, that
Mm-hmm.
a lot of the public is more aware of misophonia than sometimes their local clinician. And so social workers could add to that. And it would be incredibly helpful if a social worker could be on that team. Misophonia is a very complicated disorder. Is it psychological? Is it neurological? Is it audiological? It's all of those things, and it requires a multidisciplinary approach. And if a student needed accommodations at school, if an employee needed accommodations at work, or whatever it happens to be, I could see a social worker being a key part of that uh, team that comes together and can support that person and write letters of advocacy. And I just see such a wellspring of potential for having social workers involved in all of the different things that people need
Mm-hmm.
to get by in life with misophonia. What do
Yeah,
you
absolutely.
what do you think this is the next? Obviously, your papers are forthcoming. We'll send everybody the links when they're available, and that's very exciting. What do you see as, in addition to your paper, some other brainstorming ideas of how the social work community can best become aware of and educated about misophonia and to support people from a new paradigm, a new viewpoint that hasn't really existed in the mesosphere yet?
Mm-hmm. I think something that I really love about the social work profession is the way we center the client within the treatment planning process, within the therapy setting. And so I would encourage social workers to be open to what the client is saying. I know that there was one study that found children who talk about their misophonia, and this is ages 10 to 14, are most of the time dismissed or not believed. And so, if you're a social worker hearing a client talk about this issue, be open to that new information and view that person as an authority on themselves and the disorder. I think this is going to be a huge part of how we tackle misophonia and spread awareness. It's about centering the client, making sure that they are empowered to talk about their misophonia and kind of lead the treatment process. I had worked for a social work. I had worked with a social worker for a number of years as the client, and when I first met this person, he had never heard of misophonia, and for a long time, he was really confused about what it was. He was confusing it with hyperacusis, which would describe, hearing sounds abnormally, perceiving sounds to be abnormally high and pain in
Mm-hmm.
the ears. Um, but even though he had never heard of it and didn't really understand it for a bit, he always stuck with me. Um, and he was always interested in learning more about it. And it really did inform um, the types of interventions we did and the types of treatment I received. And I think if he had, I prior to that, I had worked with another professional who, I would talk about my misophonia, but because they didn't really understand it, it's not that they would dismiss it, but they would focus on anything else. And so I got help in other areas, but never with the misophonia. And the misophonia really is central for me. So if you're a social worker, and if you're any helping profession, listening to the client, taking an interest in what they're describing, especially if it's something you're not familiar with.
Absolutely. That's one of the things that I've never really heard of what the best solution is, and maybe there isn't one, but there's a lot of misunderstanding. So exactly like you said, let's take a high school student has misophonia. it's difficult for their teachers to understand the severity of it or just how much it impacts their life. And so you're right, they can be kind of dismissed or belittled. There's a miscommunication there, and even worse, a lot of times kids are bullied. In fact, adults can even be bullied for having misophonia because it's not understood as how life impactful it can be. Is there, maybe this is a naive question, but is there a place where a social worker could kind of step in if a child is being bullied or their teachers are kind of shunning it and not really taking it seriously and not understanding the severity of it, to mediate or educate the people involved in that a little bit better about what exactly it is? It's not a, oh, I don't like that sound. It's a life affecting disorder that has impact every day. Is that something a social worker might be able to help with?
I think so. I think in terms of explaining it to the teacher, finding accommodations, if we're sticking with the example of a school, I think the social worker has a responsibility to develop the language to describe misophonia, and help the student receive accommodations, help the student avoid the misdiagnosis that we talked about. Mm, It's a much trickier question when we're talking about other students. And this does happen. When I was in high school, I was very open about my misophonia and I wasn't quite eloquent about it yet. But I needed to communicate it to my friends in order to, you know, stay with that friend group.
Mm-hmm.
And they were mostly great about it. There was a time when I had one friend who used it against me to kind of taunt me and started making those sounds that I hate. And um, I don't think this person would ever do that now. But I think the best thing that a social worker can do in that situation is to um, help the person with misophonia learn to communicate about the disorder. Um, I think if the social worker, directly steps in, that's loaded. But I think it could be so helpful if the social worker focused on the communication skills that the student can develop in explaining their misophonia and just how big of an issue it is for the student. I also think that social workers, it's important to focus on coping skills, whether that is, both short-term and long-term coping skills. So whether
Mm-hmm.
that's breathing exercises in the moment or actually leaving the situation. And by the way, that's something that I wanted to briefly touch on because a lot of the social work research we have now describes that act of leaving to be kind of a deficit, sort of the decision to leave is avoidance behavior. I see it very differently. I see it as a helpful survival strategy. And I think when you frame it that way, it's going to be helpful for the client. If we're uplifting the client, I think we're going to get better results. And also think about everything the client is not doing when they are walking away. They're not, covering their ears and screaming,
Right.
which, some young people will do depending on a number of factors. And they're not getting into a fight
Mm-hmm.
with their friend or their loved one. So I just wanted to touch on that. But back to the question about the school, I just think developing the communication and the coping skills is really key there.
Yeah, absolutely. I'm glad you said that because the leaving might to an outsider look like avoidant behavior, but sometimes it's a last ditch effort to not lose their sanity. And I think your reframing of that, you're kind of turning the telescope around and saying, no, this actually can be a very effective way of doing it. But it can also lead to the fear of missing out. You end up missing out on things because you're leaving the situation.
Mhm.
That might be a tough thing to tackle. Something we talk about is the I guess getting our plans rerouted with misophonia. And what I mean by that is, suppose I'm taking public transportation, somebody on the bus is doing something very triggering. I'm not going to talk to a stranger on the bus about their triggering behavior. And so maybe my earplugs don't work and my breathing exercises and all that aren't really coping. So I might just get off at the next stop just to get away from it. And now I've rerouted. I'm in some place I didn't expect to be. You know, I'm at a different stop than where I planned on going, and so my trip has been rerouted. Or I decide to leave a grocery store and think, I guess I'll do my shopping later. You know, like there's this kind of improvisational um, adjustment that we have to do. Is that something that you experience? And how might a social worker kind of talk about how that's not ideal, but sometimes that's what we have to do to cope?
Yeah, I'm going to mention going back to my last response about, leaving the situation might be an effective coping mechanism. That is not to say we want the client to just always leave the
Right.
situation. We
Sure.
want to get to a point where that's not the best option every time. Um, but there are times when leaving might be the most helpful thing to do. In terms of, leaving that bus, I think I'm going to answer this more as a person with misophonia than as a social worker or as a researcher. When I leave the home, I have two functioning pairs of headphones and I have a pair of earplugs. Um, I I think that it's important for people with misophonia to be prepared for any situation. Um, And that is part of the role of a social worker to come up with those plans. You might call it a safety plan. You might just refer to it as coping skills. Um, and I think that, I would not be able, I love going to the movies. It's one of my favorite things in the world. I would not be able to be in a movie theater if it wasn't for headphones playing a mix of white noise and ambient sounds like fire crackling. And so developing those coping skills, talking about the different options someone with misophonia has. Um, there's a there was a great article on someone using beta blockers
Hmm.
an hour before each meal. And the beta blocker, which is essentially an adrenaline blocker. I know that's not the technical term, but that's how I'm going to describe it. It helps people calm down. And for this individual in the study, it completely erased their misophonia during meals. And we need a lot more research to validate whether beta blockers are going to be effective for misophonia. But starting to look at the research and seeing what has been effective so far, some people have found um, counter conditioning to be very effective, or opposite action, which is a part of dialectical behavior therapy,
Hmm.
in which um, you might know this. I'm not sure if everyone watching will know, but when you experience misophonia, there's typically also a physical reaction to it, tense muscles in particular in different parts of the body. You might feel it right below your chest, right at the start of the rib cage. You might feel it in your shoulders. And the impulse when you hear a sound is to tense up. And so there was one individual who was directed to do the opposite action every time they heard a sound they didn't like. When they hear someone making that bad sound, do the opposite, relax the muscles. And that person found it to be helpful. Their misophonia symptoms were reduced. There are a million interventions within cognitive behavioral therapy that are being looked at, and some of which have been found effective. Um, there is, it's pretty popular now to make a hierarchy of trigger sounds, um, ordering them from most mild to most severe, and then working with the most mild first, and then moving on to the
Hmm.
most severe. And then also relaxation techniques, basic lifestyle changes, I think, like exercise and mindfulness, doing a body scan meditation regularly, which over time can give you more control over your muscles and make it easier to engage in that opposite action. For me personally, this has not hit the research yet, but yoga has been the most powerful intervention for me in reducing the severity of my misophonia.
I can absolutely imagine that. And you reminded me, we do have a beta blocker study that we're going to be helping out with coming up. It's still in the early planning stage. The propranolol study that there's been a lot of interest in. So there is new research forthcoming in the near future on a larger study about beta blockers. So I'm glad you brought that up. And I had to get my earplugs out of my pocket. It's like I carry them everywhere as well.
Yeah.
My impression is, from a non-medical professional standpoint, is that each person with misophonia ends up with sort of their own toolkit of things that work for them, and it's very much individualized. So I can absolutely see yoga being very beneficial for someone and maybe not so much for other people. And do you see this very specialized, individualized approach to misophonia until we get maybe more research on more treatments or medications or anything that we can fall back on?
Yeah, absolutely. I think an individualized approach is going to be essential. And that is the role of social workers to work with the client, develop those individual approaches. And that brings me to understanding certain aspects of misophonia for social workers. It's really important to understand and emphasize that misophonia is a very idiosyncratic experience, meaning that everyone experiences it differently. The sounds that bother me might not be the sounds that bother you. And my reaction to those sounds, both the emotions and the behaviors, might be very different than they are for you. They might even be different for me than they were when I was 15. And so that's a really important, when we're talking about an individualized treatment toolkit, it's very important to understand that it's such a unique, idiosyncratic experience. It's also important to understand for the purpose of assessment and eventual diagnosis. If someone is not upset by the sound of coughing, that does not mean they don't have misophonia.
Right.
So that's an important point. And the other aspect of misophonia I would emphasize is that it is so contextual and relational. And this is going to be another part of making an individualized approach for each client. And when I say contextual and relational, misophonia, the severity of misophonia, its development, its course, will depend on any number of variables. From there are biological factors like the amount of hours you slept the night before, whether you've eaten enough, whether you're just stressed. I was a little nervous for this presentation today, and so my misophonia symptoms
Oh no.
were a little worse today. But that's part of the process. I've developed the coping skills at this point to tell the people I'm living with, hey, my misophonia is going to be a little worse today, so I might do what I need to do. But going back to the fact that it's very relational and contextual, people with misophonia find that at least when it develops, and it tends to develop in late childhood and early adolescence, people find that the first triggers they experience are being produced by family members. Um, and so someone might be really bothered by a sound if their sibling, parent, or child is producing it, but not so much if a stranger is producing that. I have found that, I'm not sure if this is supported by the research, I've found anecdotally that the that tends to generalize, and over time you will develop an aversion to anyone making that same sound. Um, but the severity will in part be determined by the identity of the person making that sound. We've also found that people who are feeling trapped or confined or unable to escape a situation, the misophonia becomes worse. So, as the social worker, it's so important to understand that and say, how can we avoid those situations and what can you do when you're in those situations? Like, are you working a job where you cannot leave a position for hours at a time? Or in the
Right.
classroom, are you stuck in a classroom? Everyone around you is making some sounds, and you feel like if you leave, you're going to get detention. You're going to fail the course. You're going to feel trapped, and the misophonia might get worse. So, in terms of developing these individualized toolkits and these treatment plans, it's very important in my mind to emphasize the contextual nature of misophonia and the idiosyncratic nature of it.
Well said. And the one of the things that I've noticed, well, to go back, I guess, to your original thing, you're right. There's not a boilerplate trigger list that everybody has. There's some that are very common, but they're going to be different for each individual. There's some very commonly known triggers that I don't have, like snoring is one. I'm not really triggered by snoring, which people are shocked to hear. But then the flip side of that is there's a few that are actually major triggers of mine that I've never heard anybody else talk about, and I'm not going to talk about them here because I don't want to communicate them to anybody.
Mm-hmm.
So that kind of unintentional, personalized aspect of it is something that we need more research on as well. I'm glad you mentioned the contextuality of it. Have you found, just as somebody with misophonia as well, that if you hear a triggering sound and you find out the source is different than what you thought it was going to be, it changes your reaction to it? I'll give you an example. My wife and I were at an antique mall the other day, and I heard what I could have sworn was like a pen clicking noise, a very common major trigger of mine. I'm sorry to mention it. Unfortunately, when we talk about misophonia, we occasionally have to talk about specific triggers.
Mm-hmm.
But when I saw that it was actually just a note card on a fan that was making that noise, it wasn't, there's no human involved or anything. It was still a little triggering, but I could deal with it once I knew it, even though the sound stayed the same, which is kind of hard to explain to somebody. Have you experienced that kind of thing where once you realize
Yeah,
this is different, that it changes?
absolutely. And we see this phenomenon happen again and again in the research, in case studies. One of my earliest memories of misophonia is I woke up to my dog Sammy licking my ear.
Mm-hmm.
And for a moment, I thought it was a different sound coming from a different person, like a chewing sound. And I was very upset for a moment. And then when I realized it was my dog, um, my whole system calmed down. I was not upset by that sound. And that continues to happen frequently, really. I think that in high school, people would often they would sort of twist a water bottle, and
Oh,
so that that doesn't bother me actually. And sorry to mention it,
no, it's okay. I
but
understand.
the top of the water bottle, the cap would pop off, and that doesn't bother me. But when I would hear that sound, I would immediately think it was popping gum, and then I would get upset, realize that that's not the sound, and again the whole system would relax. And
Yes.
I think that's a very hopeful phenomenon in my opinion. I don't have a ton of expertise on this particular dimension of it, and um, I don't know what the future research will say. But I think the fact that we can hear a sound and think it's one thing, but then calm down when we realize it's not. That to me is hopeful. Seems hopeful that we can reduce misophonia overall.
Yeah. I think there's a lot of interest in research going away. Dr. Davidenko and Dr. Samermit from UC Davis, UC Santa Cruz. The brain
I
is
believe
going.
Santa
Sorry.
Cruz with
Yeah.
visual triggers.
Yeah. The
Mhm.
context of using the same sound but with different visual associations changes how we
Yeah.
react to it. A lot
Mhm.
of interest in developing that into a potential treatment or coping mechanism.
Yeah.
I wanted to ask you a couple of things. Through our email, you had brought up some terms that are social work industry terms.
Mhm.
A few I'm sort of familiar with, but I wanted to get your perspective on it. You had mentioned that some of the ways social workers might add to the body of knowledge around misophonia. The first one you said is an ecological perspective. What do you mean
Mhm.
by that? I'm fascinated by that.
Ecological perspective or person and environment approach is just the basic idea that experience is the product of the person interacting with their social environments and their physical environments. It's understanding human behavior as it's been impacted by the environment. And so that brings us sort of back to the discussion of oppression and the different identities that might impact misophonia.
Mm.
It also it it brings attention to physical space and the ability to modify space. And so one of my favorite examples to use is from a few years ago. There was an interview on the Stephen Colbert show with Oprah Winfrey, and Stephen Colbert introduced what he was describing as an odd phobia. And he said that he knows Oprah has this aversion to gum chewing. And Oprah went on to describe misophonia. She didn't use the word, but it seemed obvious to me that what she was describing was misophonia. And she said she experiences rage when she hears people chew gum. And so um, during that anecdote and that interview, she had said that when she's on set, everyone knows no one is allowed to chew gum. At her offices, no one is allowed to chew gum. And if you don't know what misophonia is, that might just sound like a very unreasonable request. I
Mm-hmm.
see that as a potential um, healthy coping mechanism that Oprah Winfrey has chosen for herself. But the point here that I'm trying to get to is most people do not have the formal or informal power to tell people not to chew gum. And most people do not have their own offices where they can say, let's not chew gum. And so it's physical space and the ability to modify space that's going to impact the experience of misophonia. It's the access to resources, whether
Mm-hmm.
that's power or just a different room to go in. Someone with fewer resources is going to have fewer spaces and fewer rooms. Something as simple as that. Um, and so, sorry, I lost my train of thought
That's
there.
okay. No, you brought up an interesting point. I think we talked about it at our last science session with the previous one to this one, is that I think there's been times in my life when I may have inadvertently or subconsciously sought out more leadership positions in groups so that I might be able to make those kinds of guidelines.
Mhm.
If I'm just a worker, I may not have the power to do that. But there's a certain amount of privilege to that, and so I can look back at times when I thought, oh, I'm actually, theater terms, like I'm the lead carpenter on the set instead of just a carpenter. So as the lead carpenter, I can kind of let everybody know, hey, there's no, don't bring gum in here, and if you're going to eat, can you eat it outside? Whereas not everybody has that advantage. Which kind of brings me to the next thing you brought up, which is something I'm familiar with. I'm actually a certified peer specialist, which is kind of like baby social work. Like it's not, it's kind of in the same realm, but peer specialists are a little bit more specialized and not nearly as highly trained. But you bring up strengths-based approaches, which is something I'm familiar with. How might you use a strength-based approach when working with a client or a peer who has misophonia?
Mhm. So I started to touch on this a little bit with the person who is leaving the situation,
Mm-hmm.
and someone could describe that as a maladaptive coping mechanism, as avoidance behavior, or just as inappropriate. I think that a skilled social worker might describe it as an important coping skill that this person has developed, and really just framing these behaviors and experiences from that strengths approach, that what you just did, it's not a deficit, it's a strength. Because here are the here are the things you could have done instead that would have been really unhelpful.
Mm-hmm.
Um, and so working from a strengths perspective, the research supports, not the misophonia research, but social work research supports that when we start with a client's strengths, we tend to make more progress, and that the client becomes more interested in being a part of the treatment planning process. And there's more compliance with the treatment plan. So that's really the importance of reframing these behaviors as strengths. And it's important to remember that someone with misophonia is operating in a landscape in which there is no official diagnosis. In the DSM-5, there is no official diagnostic criteria, and there are very few providers who are familiar enough with misophonia to really treat it. So people with misophonia, in my opinion, are incredibly resilient and tend to be extremely creative in the coping skills that they've developed. And I think that those are qualities that we need to emphasize in treatment and even in the research.
Absolutely. That's another place that anecdotally, we see this all the time, but my experience, people with misophonia tend to be, very creative, outside the box thinkers, and maybe that's an overgeneralization. Um, if anybody has any questions, feel free to throw them in chat. I did want to ask you about, thank you for bringing that. I did want to ask you about, you've got two papers kind of in preprint review. One is on misophonia and one is on misokinesia. And maybe you can tell us a little about where those are and what your approach to including misokinesia in the social work realm. I know the two almost overlap a lot, but maybe you can kind of describe how that came about, that paper.
Sure. So for anyone who doesn't know, misokinesia is aversion to visual images or movements, such as if you are, imagine you're watching a baseball game. You cannot hear anyone chewing gum or chewing tobacco, but you can see it. If it still bothers you, that would be misokinesia. Or alternatively, if you are bothered by watching someone sort of rock their leg or tap their foot and there's no sound, that would also be misokinesia. And there are a lot of different ways that misokinesia is conceptualized. Some say it is a, some say that misophonia comes first and then misokinesia develops afterwards as a byproduct. Some say they are two totally distinct disorders. Um, and some people have begun categorizing misophonia and misokinesia as one sensory disorder, an aversion to sensory stimuli. And that could also include certain smells or even certain tastes. And so I had wanted to study misokinesia just to describe it. And I imagined it being this very kind of easy, short paper. And as I started to write it, there was so much to it. Um, Nothing short about it. It's longer than the first paper, and it gets at a lot of ideas that I would say, the first paper I wrote I'm very proud of the start there, but it's in this second paper that I think really starts to put it all together. And so misokinesia, the fact that you can take a visual of someone walking through snow and pair it with the sound of someone crunching on chips, the fact that you can pair those together and people with misophonia will have less of a reaction to it, I think that has profound implications for treatment and sort of conditioning yourself to the sound. So as we begin, as social workers begin to look at treatment options, I think misokinesia is going to be a really important consideration, and it's also going to impact our assessment tools, and it might impact the diagnostic criteria. Right now, the most prominent diagnostic criteria tend to ignore the visual element. I'm
Mm-hmm.
familiar of one that includes it, but there are two other big ones. one by Schroeder, and I apologize if I'm mispronouncing the name. I've only ever read it.
That's okay.
But one by Schroeder, and that doesn't include visual stimuli at all. And so if you're the social worker making a diagnosis or doing an assessment, let's say you decide to use that diagnostic criteria, I'm not sure what you're even going to do with the visuals. Or what if it's only the visuals? That seems to be more rare so far. Um, but also, it would make sense that we know less about misokinesia because it's so much easier to avoid a visual than it is to avoid a sound. It's easier to look away than to cover your ears. It's more socially appropriate to just look away rather than cover your ears. And also, when misophonia research was first coming into fruition around 2001, 2002, it was by audiologists. And
Right.
so we don't have any corresponding research from eye doctors. I can't remember what eye doctors are called, but you get the idea. We don't have any corresponding misokinesia research from those specialists.
Yeah, that's something. Thank you for it. That was an excellent explanation, and that's something. Misokinesia is something that definitely needs more research. Again, anecdotally, in discussions, and I've talked to a lot of people about this, we've never really seen anybody, and they're probably out there. I don't want to exclude anybody who has misophonia that also doesn't have visual triggers. But the confounding things about it are there are a lot of visual triggers that aren't associated with sounds. It's not. They're just a visual thing. And I've heard that there are people who have misokinesia without having misophonia. So there's all this kind of, I guess, pondering about it. But long story short, we need a lot more research into misokinesia. Mm-hmm. So I'm excited to see your paper and kind of get a feel for where we're at presently. Right about 4 minutes till the hour. Does anybody have any questions that they want to ask? Go ahead and throw them in chat. I wanted to take a step back before we close because the conversation we had when we first talked, we talked about some pretty conceptual things that so far our discussion has been about working with a client, advocating on behalf of a client, and spreading the word. Let's take a step back and look at kind of the bigger picture of social systems and social work and the work that needs to be done in society and in the world, not necessarily from a clinical perspective. You had some really kind of hopeful but big picture views of things that I hadn't really heard too much in the misophonia research. So maybe you can kind of tell us a little bit about, as a social phenomenon, misophonia is not that rare, we found. How might society and social systems and social spaces be ideally changed or adapt to sensory disorders and misophonia? I know that's a very vague question, but I know you have some pretty good conceptual answers for that I found very intriguing.
Well, we have to compromise to some extent or meet in the middle because we're not going to have everyone everywhere accommodate to misophonia. It's just never going to happen. But I think, and this goes back to the ecological perspective, at least in a lot of Western society, I think, and this could be the case in other places, almost every celebration is centered around food and around eating. And it's hard to tell people not to do that, but I am wondering if we can make spaces within those celebrations that are like, we're going to not eat in this section. We can eat over at the dinner table, over in this room, but this room is not for eating. Just like you might have, if someone has a substance use disorder, an alcohol use disorder, you might say, this is the dry room. And so, small accommodations like that, I think, could be helpful.
Absolutely. Yeah, that's something I've thought about. Maybe there's a blog article or something in there, but the stigma of dinner time as such a social thing. You're right. Every event, Thanksgiving dinner, Christmas dinner, business meetings, dates, weddings, you name it, they're all centered around food. And that's throughout history. The Knights of the Round Table, the Last Supper, you know, My Dinner with Andre, like everything happens around dinner. And it can be very shocking, and people can respond with defensiveness and dismissal when you say, I not only can't do this thing that's such a part of the social family gathering or whatever, so I have to abstain from it. It can seem like an act of defiance, but that understanding is so important because so many things are centered around food, and to get out of that paradigm that's so ingrained through history and culture would be tough, but would be a big help, I think.
Absolutely. And even if you, I'm just going to, just a brief point,
Sure, go ahead.
even if you cannot make those accommodations, and it might really be a big ask, but if you're the parents of someone with misophonia or the spouse of someone with misophonia, just understanding that the dinner table might not be the main source of communication. It might not serve the role it has traditionally served in your own life or in American culture or in any other culture, and finding other spaces to have that conversation.
Yeah, and it's not such a big ask. I guess a couple of years ago, Michelle and I, my wife and I, were interviewed for a UK news story, and I remember they did a split screen of her eating dinner in one room on one half and me eating dinner in another room on the other half, and they were like, "This married couple does not eat dinner together, isn't?" And it was kind of like a "isn't that sad" thing, and we were like, "No, it's perfectly fine. It's not that big of a deal." And so, kind of changing that we can talk about our days and everything without food around, and it's not really a big accommodation. Any
Yeah.
closing thoughts, Dan? We're at about an hour. This has been really an inspiring conversation. There's a lot of work that needs to be done, but having the social work viewpoint in the mix as the mesosphere grows and awareness grows, and we seek to spread knowledge and understanding and empathy about it. That's such an important part that really got my gears turning. Any kind of final thoughts on what's coming up for you and what the future looks like?
Sure. I think that in terms of the misophonia research, I'm very interested in studying some more treatment options for people with misophonia, and we've seen a couple of promising studies that suggest EMDR is a potential treatment for misophonia. And for anyone who doesn't know, that is traditionally used as a treatment for post-traumatic stress disorder, traumatic memory. But we're finding that it can be used for misophonia, and that it doesn't necessarily mean that misophonia is associated with PTSD. It might be, but that connection is not necessarily there. And so I'm very excited about that. I would also really like to understand whether somatic experiencing can be an effective treatment for misophonia. That's another treatment that's typically used for PTSD.
Mhm.
But basically, the idea behind that is that misophonia is experienced physically in the body. You have physical sensations when you hear a sound. And so somatic experiencing is all about bringing awareness to the physical sensations surrounding different memories and surrounding different emotions. And so I'm hoping in the future I get the chance to elaborate on all of that. Um, in a closing thought, I'm just really grateful to be here tonight. I think that this is going to be helpful in spreading the word and having more social workers understand and be ready to treat misophonia.
Likewise, and thank you for doing this. And you're a busy guy, and I appreciate you taking an hour out of your day to share with us. And it is, from our viewpoint, a breath of fresh air to have social work research and social work professionals coming into the misophonia community. We need those different viewpoints and new ideas, and so we're grateful for that as well. And I'm really looking forward to seeing what the next couple of years bring. When I bring it up a lot, but when I look back 2, 3, 4 years ago, what we knew about misophonia, even from a clinical perspective, so much has happened in just the last couple of years. And so that if we can extrapolate that to the next 2, 4, 5, 10 years from now, which isn't that far off, research and understanding is very active. People are fascinated about, for good reason, wanting to learn more about misophonia because it's so strange and so complex. So thank you so much for doing this. And we'll be posting the videos soon. And we'll talk again. Let us know when your papers are published. We'll be happy to share them with our community, and appreciate all of your help, and have a great evening.
All right, great. Thank you so
Thanks, man.
much, Chris.
Yeah, man. Take care.